Okay, so good morning to everyone. I hope you enjoy your Sunday morning. It's 9 a.m. in the morning in Indonesia. And allow me to introduce myself. My name is Marino Sutedjo, and I come from Indonesia. It is an honor and pleasure for me to be able to share with you this morning. And thanks to Fanta Dental for this opportunity. So as you can see, the title is the Endodontic Essentials. So this morning I will speak and share my knowledge and my experience in endodontic field. So let's get started for today. So if we speak about the endodontic, I want us to see what is actually the difference of endodontic. So the definitions of endodontic, as we can see, that it is a branch in dentistry that is concerned with the morphology, physiology, and pathology of the human dental pulp and periapical tissues, and it has two objectives. Why I highlighted this objective? Because sometimes we forget that endodontic is not just has one objective, but it has two objectives. What is the objectives? We have the treatment objective, which is we need to completely clean all the content of the pulp chamber. We need to clean all the root canals from the infected pulp, debris, bacteria, and we need to shape all the canals in order to be able to receive some irrigants and be able to fill and seal all the canals. That is the treatment objective. But this treatment objective has a final objective, which is to prevent spread of infections, to repair damaged tooth, to prevent bone from breaking down, and last but not least is to save natural teeth. Why this is important? Because sometimes if we don't think that it has two objectives, we straight away think that the endodontic treatment objective is to save natural tooth, which is it will not be happening if we are not completely clean all the systems inside the root canal systems. So we need to understand that this objective of endodontic treatment is to clean and seal first. And if you can fulfill this objective, then the final objective of the treatment, which is saving natural tooth, then it will be more predictable. So as you can see in this case, you can see the lesions on the mesial root, and then our treatment objective is to clean, find all the canals, clean and seal it, and restore it nicely. And after the follow-up, you can see the lesions is healing. So this is the final objective of the endodontic treatment. This is also a fractured tooth of a mandibular first molar. And after the root canal treatment, the restorations and the final objective, this is 15 years after follow-ups, is still there. It is still functioning without any symptoms. So our final objective for sure is to have a long retentions of the tooth as long as possible without any symptoms and not just a good white lines, because sometimes good white lines doesn't guarantee a success of long-term survival. But we need to understand and to think the first treatment objective is to clean. And if you can clean and you can seal, then the final objective will be achieving. So this morning, I will speak with you about this essential. So how we can achieve this final objective of the endodontic treatment, we need to fulfill these four steps, which is the access cavity. We also need to shape our root canal. We need also to obturate, and last but not least is final restorations. Why maybe some of you heard about the endodontic triad, which is the endodontic triad is only access, preparations, and obturations without restorations. But I think restorations, it is something important if we are talking about fulfilling the final treatment objective. Because if we see from the literatures, we know the failure of endodontic failure, 73% of it is not related to the endodontic treatment failure. Instead, it is related to the restorative issues. Sometimes we have fractures, we have restorative failure. So we have to highlight it as well. If we want to only achieve the treatment objective, then we can exclude the restorations. But if you want to achieve the final objective, which is, I think everyone wants to have it, which is a survival of the long-term retention, then it means we also need to think about the restorations. look at these cases. How can you say it is a good restorations and good safe dentin? How many pin retain I can see in this case? It's very ridiculous. And so what our job is, and what my job is to find all the canals. In this case, is a C shape, clean everything, seal everything, and restore everything, and make a follow-up. And this is the 5 years follow-up. As you can see, the lesions is healing, the symptoms is fine, the tooth is functioning, and this is the final objective of endodontic treatment. So if we can draw the animations and if you can see the big picture, so we need to start it with the access cavity, remove all the bacteria at the coronal sections, and then we need to shape our root canal to create a space for irrigants and also to create space for our sealing material. And then we have to follow with the final restorations, adequate final restorations, and we can see that the healing will occur and the tooth will predictable to have a survival long-term result. But we know sometimes this is also a challenge for us because to do endodontic treatment itself, we need to create access cavity. And from the literature, from the research, we know that the access cavity will make the stiffness lose about 5%. And not to mention, if we have a case that is, for example, the tooth has broken down, sometimes we have the loss of two marginal walls. The mesial wall is gone, the distal wall is gone. So we have 66% loss of the tooth stiffness itself. So from this case, we know that it is not also important to reduce bacteria as much as possible, but it is also important for us to save as much as possible the dentin inside the tooth that we need to treat. Because the more dentin we have, of course, the higher the fracture resistance, the higher the retention. If we have the higher retentions, of course, we will have predictable long-term survival tooth. So it means in order to fulfill these two objectives, which is the treatment objective and final objective, we need not just to clean the bacteria, but we need also to maintain as much as practical the dentin, because the more dentin we have, it means the higher the chance the tooth to survive in long term. So this morning, I want us to think a little bit different about what is the concept I talk about, the less is more. So what is actually less is more in endodontic fields? It is applying the minimally invasive endodontic. There is a good paper from Brooklyn in 2015 that he described what is actually the definitions of minimally invasive endodontic. From many definitions, we can be agree in one terms, that is minimally invasive endodontic. It is applying about dentin preservations. How we should preserve dentin, not as much as possible, but as much as practical. Because in our philosophy of our group, the Style Italian Endodontic Group, we believe that saving tooth structures, it is an important parameter for a long-term success, which is the more tooth structure you have, it means the long-term success for survival tooth, it is higher. So therefore, less is more in endodontic concept is just a preservations of tooth structure. So I want us to be, let's say, be more specific on the four topics that I applied previously about how if we want to achieve this survival for long-term survival. First thing first is access cavity. We know we cannot do any endodontic treatment if we don't do access cavity. So the access cavity, basically, in my opinion, is the most important step in endodontic treatment, because it is the first step that we do. Incorrect access cavity, of course, will make our procedures more difficult and more challenging, and it will also create more risk. But a correct access cavity, it will also simplify your procedure. It will speeding up your shaping, your cleaning, because we can create more maneuvering space for the instruments. We can have a direct patience to be able to find all the systems and the orifices that we should find. And also we can have an easier irrigation flow of our irrigants inside the root canal. So a good access cavity, it should follow these few factors. First thing first, we need to have a straight line access cavity. In order, we need to be able to get a visibility. And if we have a straight line and good visibility, we also have a need also the good of infection control. And functionality, of course, it is one factor that we need to fulfill. And last but not least is dentin preservations, in order to be able to make sure the predictable of long-term survival of the tooth. And if you are talking about access cavity, it has been a standard and it has been a basic for us who doing an endodontic treatment. That straight line access, I believe at this moment, is still one of the most predictable type of access that we can do in our daily protocols to be able to find our systems and to do more easier protocols of the endodontic treatment. But this very good paper by Omar Ikram, he's an Australian guy, back in 2009 about the microcity of changing volume of the premolar after we are doing endodontic treatment. And as you can see here, after root canal access cavity, the highest volume number of the reducing, it is the greatest happening at that phase. So after the caries removal, we are reducing 8.3% hard tooth tissue loss. And after access cavity, we are reducing more, which is 12.7%. And after root canal preparations, also after fiber post and casting post preparations, hard tooth tissue loss also become greater. But I want us to see the difference, the significant difference. It is happening on two phases, which is after access cavity, it will increase 4.4%. And after creating casting post preparations, also it will increase 4.1%. So in this case, we know that in order to be able to have more dentinal tooth structures, we need to be careful on these two procedures in which access cavity and creating space for the post. Ikram said that the access cavity and the post-space preparations are the procedures that cause the largest loss of hard tissue structures. So therefore, I will highlight this access cavity because we know this is the first steps that we need to do. And this is the first step, and this is the step that create the most hard tissue loss of our procedures. So therefore, in 2010, there is a concept of the modern molar endodontic access cavity, and this concept has been proposed by Clark and Academy. Therefore, we might heard about the CK principle. In this concept, we still create access wide enough to contain irrigants and to have a direct patients, but at the same time, we are preserving the pericervical dentin structures in order to have a good fracture resistance. And what is actually the pericervical dentin? Well, actually, this is the area that we believe this is the most susceptible area to fracture from occlusal forces, which is this is the most important for us as an endodontist or as a dentist who perform root canal treatment to maintain, because this is the area that can withstand the highest occlusal force that can the tooth accept it. So defining the pericervical dentin area, or we can say the PCD area, is 4 millimeter above the crestal bone and also 4 millimeter below the crestal bone. So as you can see, image on the left, you can see the red square and also the green square. There is actually the PCD area that we should maintain. And if we can see that this is area that is quite important, so the 4 millimeter above the crestal bone can be maintained if we are creating a good access cavity, but the 4 millimeter below the crestal bone, or as you can see the green boxes, it is the area that we should maintain during our coronal preparing or during our root canal instrumentations. So if we want to have a more predictable long-term survival rate, it means this is the area that specifically that we need to preserve. Therefore, nowadays, I am more accepting and teaching or maybe suggesting for us to create more conservative access cavity. And why is that? And because we have to believe the biomechanical advantage and the true basic evidence about this type of cases. What Gianluca Plotino and Nicola Grandi from Italy also doing a research in 2017 about 3 types of access, which is the traditional access cavity, and a bit smaller as a conservative access cavity, and the ninja access cavity. But I have to be more clear, and I want, and these guys are also wants to be more specific. The traditional access cavity, it is defined if we reduce the volume more than 15%. Conservative access cavity, it means that we're reducing up to 15%. In ninja, it means we only reducing up to 6% of the tooth structure of the coronal part of the tooth. So from these three types of access cavity and the research about the fracture resistance, they also agree that the traditional access cavity show a lower fracture strength comparing with the conservative access cavity. But the conservative access cavity and ninja access, they did not have any significant difference. So therefore, what the 𝗘𝗀𝗀𝗃 principle taught us about preserving PCD area, it is exactly on point that we need to reduce a little bit of our access cavity from traditional into the conservative, but not going way too far than doing ninja access cavity, which is it has no significantly strong evidence that it will increase fracture strength. In fact, if we are talking about the ninja access cavity, although we know they did not increase fracture resistance, this type of access cavity also has more risk. You can see from this journal, if you are doing a smaller access cavity, they divided into 3 stages. Stage 1 is without magnification, stage 2 is with magnification, and stage 3 with magnifications and ultrasonic explorations. And you can see the green line is the conservative and the purple line is the traditional. So by making a smaller access cavity, you need to understand that you need to apply more time, more efforts, and of course the magnifications in order to be able to detect the root canal systems. As you can see in the stage 3, even we apply magnifications and also we apply also the specific technique to explore, even the number of us detecting a root canal is higher in the traditional access cavity compared to the conservative one. So we know if you are doing ninja access cavity, the higher chance you can get a missed canal, but you don't have any benefit instead in terms of fracture resistance. So therefore, we have to understand that making the access cavity smaller is important. But if it is too small, then it means you make your life more difficult because the difficulty is increasing. And not to mention also the risk of getting a missed canal also is higher. So in access cavity, in less is more concept, I understand that first I will create my small access cavity. By means small is conservative. If I can get vision, if I can get good scouting and create glide path, then I will maintain the access cavity and I will continue my root canal shaping in order to maintain a less is more concept. But if I cannot get a good vision in a small access cavity and I cannot have a safe glide path, then I will definitely make my access bigger, because my concept, although I trust in less is more, but my principle is it better for me to lose 1 or 2 millimeter at the coronal than I lose 1 or 2 millimeter at the apical, because in that case, I cannot clean the bacteria inside the root canal system. As you can see in these typical cases of molar, maxillary molar, I try to create a conservative access cavity, maybe a bit too conservative. But if you see, if I make the outline or my access, let's say a bit 1 millimeter or maximum 2 millimeter larger, you can see that you will more see clearly and you will able to detect more systems inside the root canal. If you try to stick with the conservative access cavity, it will create a missed canal, then it will create also the failure chance in the future. So this is after the obturations. So in our groups, we believe that now we try to make our conservative access cavity by mean the dentinal preservations. Mostly we try to conserve at the pericervical dentin area, but at the same time we are not sacrificing our effort our simplicity in order to create instrumentations of our root canal systems. As you can see, this is after the access cavity. The pericervical dentin area is still maintained. We can still easily insert our initial instruments into the root canal until it reached the working length, and we can still shape, we can still clean, and we can still fill nicely without any risk, without any, let's say, failure in the future, and we still can maintain dentinal preservations as much as practical. So first thing is the access cavity. It is something that we definitely need to put attention on it. We need to try to be more conservative in order to be able to preserve 4 millimeter pericervical dentin area above the crestal bone. So now let's talk about the second phase, which is shaping. We know that shaping, it is undeniable. It is also important because we know unshaped root canal cannot be cleaned. And if you want to shape, I believe that 𝗘hes-𝗱ឆિ, it's still, until now, it's still one of the concepts that I respected the most. And I believe also it is the concept that he introduced us many, many years ago, and it's still applying until this recent, or maybe until today, with the shaping concept that we should apply. And what is the objective of shaping according to him? First thing first, we need to create a conical space, a funnel space from access cavity to the apex. It means the cross-sectional diameter should be narrower every point, and we should maintain also the positions of the apical foramen, and we also need to maintain the originality of the root canal shapes. And last but not least, what he said, we need to maintain the apical foramen as small as practical. He did not say as small as possible, or he did not say as small as case file number 25, but he said as small as practical. So before we are speaking about that, let's do a brief history about mechanical instrumentations. If we are looking about a brief history at the year of, let's say, the late 90s or maybe the early 2000s, we know we are in the nighttime era. And at that era, we are taught about the early coronal enlargement. In this paradigm of shaping, we are using our instruments to remove the coronal interference in order our file can go straight into the root canal without any interference from the triangular dentin. But you know from this image, at that stage, we are removing a little bit more a pericervical dentin area that is extend 4 millimeter below the crestal bone. And this early coronal enlargement is changing into the selective coronal enlargement, which is by the definition is the dynamic removal of the coronal interference during the root canal preparations using our specific nighttime instruments. And in this selective coronal enlargement, we know at that time we can use this many instruments, and this is also applying until now, that you can use this specific instruments to create orifice opener, and this orifice opener in order to have a straighter insertions of our file. And you can see also in this case, we have a possibility of reducing more pericervical dentin area. But at that time, we don't have any choices because the aim of the concept is to create space coronally and to remove interference, because at that time, we don't have any advantages in the material of our instrumentations, the material of the metallurgy, and maybe also the concept and also the technique and the design of the specific instruments. But the questions at the time, how big we should create the space for the length for the irrigants to be effective. So this I took from the many textbook that we believe more than a decade, the preparations has to be stopped at least at the size more than 25. And this is, I think this is also a reasonable numbers, but we have also to think that our root canal anatomy is not perfectly round shape. Look at this image. You can see it is not completely oval. By fact, it doesn't have any shapes, specific shapes. It has an oval look-alike shape, but it has a big area in the middle part. It's more like a circle around shape. And this is also quite important that the most common physiological foramen, in fact, it was oval. It is not round. And it has been proven in the literature that the 70% of the foramen is not round. In fact, it is oval. So what we thought that it might have a round shape, we have to think again. And this is also a nice evidence that no matter how hard you try to shape your canal, 15 to 30% chance of our root canal walls still untouched by the instruments. Even you use, let's say, 25 or 30 of 35, because what we think our root canal is round, the reality is not round. So our instruments, for example, 30 instruments, it's only hitting the outer, the outer part of the file, but they cannot hit the outer part of the root canal if the root canal is oval, it's not round. You can see this is image from the scanning electron microscope. You can see that the apical foramen is not round, it's oval. Therefore, should we go as big as possible? Should we go, say, must be at the 30 or 35 or 40? Then we should think again. You can see in this image on the left side, if you use, for example, 2506, the wall, in the inner wall, still cannot be touched by the instruments. Even you increase the size of your instrumentations until 35 or 40, the file still tends to be more in the outer wall than with the inner wall of the canal. And what is also a good paper from 1956 that it said the poorer long-term prognosis for the larger apical preparations. And not to mention in 2011, there is a good evidence and a good literature that has been published in Journal of Endodontic Treatment that the more cracks were observed if you're using larger file sizes. Instrumentations using the NiTi rotary files could potentially cause cracks on the apical root surface if we are pushing into a larger file size that we use to shape our root canal. So this is the case that I have. So it looks like just a simple failure in endodontic cases that we can do a retreatment. But in fact, when we do more about exploring the possibility, it turns out it is not simple at all. It has a vertical root fracture. It means this tooth has to be extracted. So you can see, although I cannot say it is 100% because of the bigger preparations, but we have to understand that the bigger instrumentations that we do, it will also increase the risk of having more failure, which is the crack. And this is also 𝗘𝗶𝗶𝗋 in 2018, also in Journal of Endodontic. They designed the root canal taper influence on the fracture of the tooth, and they said the result that increasing the tapering of root canal preparations can detrimentally affect the root fracture resistance. And you can see on the right side the diagram. If they are shaping with the taper 04, then the fracture resistance is the highest level. Between the 04 and the 06, the significantly is not so different, but by increasing 6 to 8 and comparing 4% to 8%, you can see the significantly difference in means by fracture resistance forces. So the material, if you are talking about the material, also in late 90s, we know about the nickel titanium, which is nickel titanium has a good advantage because it gives us flexibility. You can bend the files into these shapes, but at the same time, it also have a bad influence because it has a memory shapes. By memory shape, if you are pushing your files in this direction, the file will not stay in these directions. The files want to be straightened out because the material of the NiTi has this the memory shapes properties that it wants to go back into its original positions. So what happened if I put the NiTi file at that time into this position, and I put it and make it rotating, and at this stage, you can see there is a compression and tension happen in this file. It only takes less than 20 seconds, the file will definitely break. because the 𝗘𝗘 wants to turn back into its original positions, which is strengthened. So at the same time, they are pushing the shape of the files into a curve shape. So therefore, this compression and tension happen at the same time, and at the same point, they will break. So, but what is so interesting about the 𝗘𝗘 itself, because the 𝗘𝗘 has phases that can be changing by the effect of temperature. There are two phases of 𝗘𝗘. One we call the Martensite. In this phase, it is responsibility for these elastic properties. And in austenite phase, it is responsible for this rigidity of this file. And this Martensite phase to austenite can be turned back and forth by using or applying the temperature. So, for example, the heat treatment, if I have a 𝗘𝗘 and I cool down the 𝗘𝗘, it means at that stage the 𝗘𝗘 will be at the Martensite phase, which is it will be more flexible. But if I increase the temperature or if I heated the temperature, so it means the file will be in more austenitic phase, which is it be more stiff comparing when we cooling down the 𝗘𝗘. So this specific properties of the 𝗘𝗘, it is something that now we are using it, and by the advance of the technology, we can do a heat treatment for our instruments before before they are going to be our root canal instruments. So in Fanta, they have several types of the material that is also a heat treated. We have a AFL, which is a slightly martensitic, but we also have the AFH, which is a highly martensitic material that used to be in our root canal instruments. And the new material from Fanta that is used in the rising rotary system file, it's called a Pro Wire, which is, as you can see, this is the rising file 2504. If I bend the file like this, it will completely stay in the positions. It will not go back into the straight positions. And this will give us advantage. So now you can see I try to bend into an S-shaped position, and it's still going to be an S-shape. It will not changing into a straight. So this will give us advantage. You know, if the file is not strengthening, it will shape more conservative inside the root canal wall and not to sacrifice more dentinal structures inside the root canal wall, because its metallurgy properties can retain the shapes of the file. So we know now, in order to save more dentin and save more perisepulchral dentin area 4 mm below the crestal bone, in order to be able to safely arrive at the apical and to make sure our lubricants can go into the length, it means our instrumentations need to preserve the structural dentin strength. Also, at the same time, it needs to provide a flexibility and achieve efficiency, but we also need to have a comfortable, smooth, effortless, and simple to use instruments. So nowadays, what we do now in a modern era, we are not doing any early or selective coronal enlargement, but we are doing the simultaneously technique. What is mean by simultaneously technique? That we use instruments, that small instruments first, because we believe it will save more dentin, but at the same time, it can also reach the working length in a safer and a more comfortable way, because we now have the advantages of the metallurgy of our files and also the design. Today, it is my honor to introduce the new rotary file systems from Fanta Dental, which is called a rising. If we see these features of the rising, it has a specific cutting angle to improve cutting efficiency, and it has also a variable taper design. It is not a constant taper. And because of its variable taper design, it will also create a maximum debris removal. And they have a special designs at the apical to fit the cone or to make the easier procedure of our obturations. So the lineup also is simple. It starts by the coronal or orifice opener if and I have to make sure I underline if you need it. But I rarely use this type of file because I believe with the metallurgy, with the new advantage, we can easily reach the working length with the first file. In this case, is the 1303. So basically, if you see the lineup, usually what I do is I'm using the 1303 as my glide path file, as the first initial rotary file that I introduce into my root canal, and then I follow with the 2504. And if I need in some cases, then I will go with 3004 and the 2508. But you can see here, the biggest taper is only the 5%, and the majority taper is the 4%, which is, we know now, we try to reduce as much as practical the pericervical dentin removal of the coronal part of the root canal. And because it's also applying less is more concept, which is the minimally invasive endodontic, the maximum diameter of the coronal shape is only 1 millimeter. And therefore, we understand that it doesn't cut that much in the pericervical dentin area. So because the maximum coronal size of the file of this rising file is only 1 millimeter, so you know, if you see from the arrow, it will still keeping the pericervical dentin area in a good way. And since it used with the ProWire metallurgy, it has a good chance of bending it before we introduce into the root canal. And so now you can see from this image, the journal said that the impact of the pericervical dentin fracture resistance, it has the bigger impact at the coronal access preparations. Therefore, we need to apply as the conservative access, but not to be a ninja access. And also the canal flaring, which means the coronal part, we need also to be considering to reduce the pericervical dentin area as much as practical. So the sequence, usually I will start to irrigate my root canal before introducing any file, just to make sure that the grease is out. And I'm using my K file just to scout and to make sure my working length with my apex locator. Okay. If I can reach my working length with K file, so I now make sure with the apex locator and I know my working length. After I know my working length, I'm straightly use my rising R1, which is 1303. And since this is a rotary file, so I put it on my endodontic motor with the speed of 450, and I'm using the torque of 2.5 torque. As you can see, the material is heat treated, so and it's effortless, comfortable, smoothly insertions until it reaches the working length. Make sure you make the file keep moving, not stay in one positions. And if you are already reaching the working length, it means it's time to say goodbye. So you do not need to repeat it in several times. After you insert your first R1, make sure you irrigate, you flush it nicely, and then you can continue with your R2, which is the 2504, gently, effortless until it reaches the working length. So slowly in, and if you feel any resistance, take it out. You go in. If you feel any resistance, take it out until it can reach the working length. And if it is reached already the working length, then it means it's time to say goodbye. You do not need to repeat it several times. It will reach the working length. So make sure irrigate well and check if it is okay. Then you only need 2 sequence of files, which is simplicity, as I mentioned you before, to reach a complete shaping of the root canal, and you can continue with your irrigations and you can continue with obturations. This is also interesting cases. As you can see, the patients complaining of painful, spontaneous pain, and the patients cannot take any cold water. So it means we know there is a sign of pulpitis, but the tooth itself, it's still in, let's say it's still quite intact. Only there is a small filling in the distal part of the tooth. But from the X-ray, I know there must be something wrong because you see there is a calcifications or a fibrotic sign in the pulp chamber. So I asked the patients, will you okay if I remove the small fillings? Because I'm really afraid that I might having a cracked tooth syndrome. And You bet, you can see it is a cracked teeth. So I know if it is a cracked teeth, one thing for sure, we cannot know how deep is the cracked ends. So what I do know, I need to perform my root canal treatment as soon as possible, as fast as possible. And I need to maintain as much as practical this dentinal tooth structure in order to still to have a still good fracture resistance, and to finish also the final restorations as soon as possible. And in order to do that, I also need helps from the instrumentations that apply or adapt these minimally invasive systems. So this case, I finished all the 4 canals with the rising systems. And what is the advantage of the rising systems? As you can see that this file is made from the pro wire heat treated material, so it is easily can be bent. So how I'm going to have an advantage of this file, as you can see, full irrigants. So now you can see I pre-bent my file, so I don't need the previous concept like coronal enlargement to make it large at the coronal part in order to have smooth insertions of the file, because I can now pre-bend my files and it will be staying at the same position, and I can still shape my root canal safely, effortless with this file. So you can see how the debris is at the apical part. It's fully packed, so it means I know my file already touched the most part of the apical, so I don't need to make it larger. I just can continue with my 2504. So continue with your irrigations, activations, and make sure you activate your irrigants because it is important. And after you irrigate your irrigants, you can make sure you have more cycles to be completed in your irrigations protocols. And after that, you can clean, you can flush, you can dry it up, and you can do your obturations. In this case, I'm using a bioceramic sealer and applying a single cone technique, which is I'm using also the 2504 𝗘𝗀𝗀𝗀, applying the same size as my final shaping size with the rising 2504. And this is the results of the shaping. This is a radix entomoloris with the 4 canals, all stops with the 2504. And since it's a crack, I need to, as soon as possible, to cover it up with an indirect crown. In this case, I'm using a lithium disilicate crown to make sure I have a good bonded to the surface and to hope to have a good fracture resistance. And as you can see, I did not touch the pericervical dentin area that is in the 4 millimeter below and above the crestal bone. So what the shielder said, keep the diameter as small as practical. I believe also it's applying to the less is more concept. By mean, you need to create a volume by using shaping, and the shape is not dictated by what size you should stop, but it is dictated by the anatomical evidence. If you can shape your root canal until only 2504 and you can make sure you can activate your irrigants, it means you don't need to make it larger. But if your irrigants cannot flow to the length because of it's too small, then you might go for a bigger shaper. So also it is applied in this rising. In some cases, if you think the 2504 did not cut anything, you might go and increase using the R3 and also the R4. But not mandatory, but in some cases that you need to be more larger. So the next step of the factors that can increase our survival is the obturations. But well, actually, if you are talking about the obturations, the principle is always the same. Good preparations root canal makes a good obturation. So there is no questions about how we can achieve our good obturations, but the questions to ourselves how good we prepare our root canal. Is if we're doing good preparations, it means we will have also a good obturations result. And nowadays we are understanding the use of the bioceramic sealer, in which the concept of the bioceramic sealer, because the material itself, it is also a good material because it will increase the flowability and consistency. and mostly because it is a hygroscopist and it's also hydrophilic, and it can adapt chemically into our dentinal wall. As you can see, this is the DE is the dentinal, bioceramic sealer is the BC, and the 𝗘𝗀𝗀 is the GP. There is no void area, which is all RB and homogeneous continuations. Comparing to the conventional sealer, we can see there is a void between the sealer and the dentin, and also some void between the sealer and the 𝗘𝗀𝗀. This is something that we do not want to have. So nowadays, in cases like this, as you can see, it's a curve. So we really need an instruments that we can rely on its flexibility, on its capability and achieving a safe and effortless way into the apical, and at the same time also preserving as much as practical the pericervical dentin area. And as you can see, after shape until the 2504, I continue with my obturations using a single cone bioceramic sealer. Inject it into the canal slowly and make sure it can cover all the root canal walls. And after that, you just apply your 𝗘𝗀𝗀 that fit with your instrumentations. And this is after instrumentations and after obturations and after also restorations. We can still maintain the curve of the canal, and at the same time to reach also the working length and preserving the pericervical dentin area. And last but not least part is how we also need to have a good restorations, because it's just like building a house. We will not selling a house without a roof. Therefore, if we want to do our endodontic treatment for our patients, we also need to provide them with a good coronal sealing, because the patients are not well served if the endodontic treatment is successful, but the tooth fails because of the restorative part. This is a good journal by Marjorie, one of my favorite in endodontic gurus. And the objective, if we are treating the endodontically treated teeth, we need not just to remove the source of infections, but we need to also restore and function. It means we need to preserve as much as practical the dentin tooth structure. We also need to prevent infections and reinfections, and we need to also rebuild the aesthetic part of the tooth. This is one of the classical journal that I always bring to any opportunities if I'm talking about the endodontic treatment, because if you want to achieve a highest number of success and survival rate, you need to have a good endo and good resto. You have a good endo, but you don't have good resto, it means you have bad resto. You can see the success rate going down from 92 to 40%. It means you have 50% lowering success rate if you don't have good resto. So this is also one of the classic journal in 1991. This journal is involving 116 teeth that is extracted from the BC group practice, and they are evaluating the cause of failure. You can see the failure of the tooth that need to be extracted. The highest number of failure, it is caused by the prosthetic failure and not caused by the endodontic failure. So therefore, we now understand restorations part also play an important role to fulfill our final objective of endodontic treatment, which is safe natural tooth or for survival. And this restorative factor should be ideally include the amount of the distributions of the remaining tooth structure, the amount and distributions also about the occlusal forces, and the type of the final restorations itself. So this is the last case I share with you. As you can see, this is the PFM crown, and there is a lesions. I said to my patients, I'm also afraid about the possibility of having a vertical root fracture in this type of lesion, but I try my best. Hopefully it is not a fracture, because not always the J shape always a fracture. In this case, I finish all the shape, shape all the 4 root canals. I follow with my restorations. I did not put any post, and I continue using lithium disilicate crown in this case. And you can see this is the follow-up 3 months after, 1 year after, and 2 years after the lesion now is healing. The bone regenerate, and the patient has no symptoms, and the tooth still functioning. So my take-home message today: Less is more in endodontic is applying the concept of minimally invasive endodontic. But we need to understand, applying this concept, it also requires a depth of knowledge of tooth and root canal anatomy. The desirable of doing this type of concept is just the interest of the patients to preserve the tooth structure for more predictable long-term outcome. And rising is the new file from Fanta is also one of the instruments that can help us to achieve this concept in order to have to save more dentinal tooth structure, especially pericervical dentin area 4 millimeter below the crestal bone. So I thank you very much for this opportunity, especially to Fanta to have this 1 hour opportunity, and I'm thank you to everyone who participated. I know this is Sunday, it's time for you to relax at home with your family, but you spend your time with me sitting down here for 1 hour. So I really thank you very much, and I hope to be able to see you in the next event of the webinar, or I'll be able to see you in the next event in the near future. So thank you once again, and goodbye.